Welcome to Pearls and Polyps. I'm your host, Benjamin Levy, a gastroenterologist at the University of Chicago. Today, we are excited to feature Dr. Neil Stollman, who is a gastroenterologist and chief of GI at Alta Bates Summit Medical Center in Oakland, California. Neil Stollman is the past chairman for the American College of Gastroenterology's Board of Governors and currently serves as treasurer for the Board of Trustees. To further our field, Dr. Stollman is currently serving on a committee working to update ACG's diverticulitis guidelines. Neil Stollman was first author in 2015 for the American Gastroenterological Association's guideline paper for the management of acute diverticulitis. Dr. Stollman's work in this field dates to 2004 when he co-authored an important article in The Lancet about diverticulitis management. Thank you for joining us today. Could you tell us about the differences between diverticulosis and diverticulitis? Also, what are the symptoms associated with diverticulitis?
Sure thing, Ben, and thanks for having me along, and hello, everyone. I'll actually just edit your preamble a little bit, Ben, to tell you I'm a really old man, older than it seems like you're aging me, because I wrote the ACG guidelines for this back in 1999, believe it or not, a prior century. And to the new guidelines, in fact, they're being approved by the Board of Trustees as we speak. So that's 27 years of worrying about diverticulitis and diverticulosis.
That's amazing.
Really, yeah, that means I'm an old man. But so you asked for semantics, and let's start with semantics because they matter. And, you know, I sometimes think diverticular disease semantics is kind of like the lactase, lactose, lactate, kerfuffle. None of our patients know the right words for that because it was sort of bad naming. And similarly, we have diverticulosis and diverticulitis, and they're very different things, of course. So for the non-clinicians who are listening in, diverticulosis simply means you have pockets in your colon. We mean diverticulosis of the colon. There are, in fact, other organs that can do that too. But for today's purposes, we're going to talk about pockets in the colon. And in this country, about half of our elderly have them. So it's not a rare event to have the pockets. That is osis, diverticulosis. A small subset of those people get sick, get a consequence of their diverticulosis. And there are two main ones we're going to talk about. One today, they can bleed. That's not today's agenda, but they can also get infected. And of course, we call that diverticulitis. Tonsillitis, appendicitis, right? Itis is inflammation of the diverticula. So diverticulitis is an infection or inflammation in typically one pocket, actually. That's all it takes. You have a lot of pockets if you have osis, but one of them gets infected and inflamed and blocked, and that makes you sick. And by sick, in this case, you asked what the symptoms are, Ben. Typically pain. That's what most people will come in with. It'll hurt. We can talk about where they are. Most people have pain in their lower abdomen. It's not immediate. It's not a knife. It's sort of subtler in its onset, and it kind of grows slowly, and it's somewhat vague in its nature. Again, most people can't take one finger and point to that one spot. Most of the time, they take two hands and kind of put them over their lower belly and say, it's uncomfortable there. And that's where most people come to attention.
Great. Could you review with us how you initially got involved with diverticulitis research?
Yes, although it's not a really good story. I was a child. I said I'm an old man now, but I was a child at my first job ever at the University of Miami in 1998, a long, long time ago in a galaxy far away. And a senior faculty member, Jeff Raskin, who's retired now, was asked to write the ACG guidelines. And at the time, at least, he was allowed to bring in some young pup like me to help him write those guidelines. And I was very much a youngster at the time. I did not have an academic or research background. I was an academician, but I did not yet have a research background. And I was kind of just lucky enough to be in the right room at the right time and helped write that guideline that got published in 1999. And then that, of course, piqued my interest, and I started to do some research and a lot more writing, and it's sort of been one of the main foci of the next 27 years of my career, I guess.
That's really cool. So I know that lack of dietary fiber is a risk factor for the development of diverticulosis. What advice would you have for patients, let's say in their 20s and 30s and even early 40s, if they want to prevent diverticulosis development later in life?
You pointed out, Ben, that fiber is inextricably tied to diverticular disease. We're going to talk about some other things perhaps later, but we do think this disorder has been conceptualized actually as a fiber deficiency. We talk about vitamin C deficiency and scurvy and vitamin D deficiency and rickets. I may have those right or wrong. I don't know. But diverticular disease has been conceptualized as literally a deficiency of fiber. And if you look at simply communities that don't eat a lot of fiber, they get more diverticular disease. And if you look at communities that eat a lot of fiber, for example, vegetarians who typically eat a lot of fiber, they get less diverticular disease. No animal gets diverticulosis unless we feed them artificially and take away their fiber. So you can give rats or dogs diverticular disease simply by feeding them a diet with not enough fiber. So that points pretty clearly that fiber is at least one of the really important parts of this. And to your direct question, Ben, which is what can someone do to not have to care about this podcast, is eat a lot of fruits and vegetables, basically. Eat a diet high in dietary fiber, relatively low in fats and red meats. I'm not suggesting that our listeners have to be vegetarians or vegans. They don't. But generally speaking, more fiber, more fruits and vegetables, less fat, less red meat is arguably the best thing we can do.
I've been working on with this with my patients, and especially if we identify diverticulosis on a screening colonoscopy, really trying to increase their fiber intake so that we can try to prevent diverticulosis from getting worse. Now, approximately 4 to 5% of patients with diverticulosis, note that's the presence of diverticula without infection, go on to develop an episode of diverticulitis in their lifetime. Could you tell our audience about presenting symptoms of diverticulitis, including geographical area of their abdomen, and what physicians, both primary care doctors and gastrologists, should be looking for when patients come to see us or they send us a MyChart message about their abdominal pain?
As I mentioned earlier, it's typically the lower abdomen. Depending on the patient, it's more often than not left lower than right lower, but that's a really loose sign. The sigmoid colon, which is where most of us have diverticulosis, is kind of a floppy part of our colon, and it can be left lower, mid lower, or right lower. So it's hard to draw a firm conclusion from laterality, right or left, but very typically lower, very typically kind of a dull pain, not a knife, not a needle stabbing you, not onset at 9:02 a.m., but rather, it's gotten worse during the day. It's sort of a slower onset. Sometimes fevers, but not always. People can feel little chills or a little bit of fevers. Sometimes the bowels can change a little bit when the colon is inflamed. It's not really a diarrheal illness at all or a constipating illness, but the inflamed colon misbehaves. So people will often report alterations in their bowels. But the hallmark symptom is really lower abdominal pain. And they're going to call or send a message or see a provider. And then we're going to examine them, of course, and try to get a sense of what we're feeling and how severe it is. I'm not someone who sends everybody to the ER, but for the first time that someone has this, we can talk about recurrent attacks. But I think most people who do this abruptly probably need to be seen in an ER, because you can't do the things you need to do in an office for this. You probably need some lab tests, and you probably need some imaging, most likely a CAT scan. That's how we typically make this diagnosis. So when the clinician has a real concern that this could be diverticulitis, not osis, probably that's driving towards don't race the car through the stop signs. Nothing bad's going to happen in the next hour. But you're probably getting to an ER to get someone to lay hands on you, check vital signs, check some lab tests, and most likely get some imaging.
Those are some great recommendations. Now, could you review for us the differences between complicated and uncomplicated diverticulitis?
Yeah, most people, fortunately, have uncomplicated diverticulitis, and most of this conversation will likely relate to that population, which is probably 90% of us who get this. Complication means it's gotten worse. Something bad has happened on top of the inflammation and infection. And the most common complication is something we call an abscess. And what that really means is a collection of pus, like a giant pimple, not to gross out our listeners, but that's what it is. The diverticulitis, sort of by definition, is a little tiny microperforation. It's not a free perforation. Your colon doesn't open up and just everything spill out, but a tiny little area does. And an infection sets up, and there can be pus literally there. And when we can see pus on imaging, we call that an abscess, a collection of fluid. So that's probably the most common complication. It can rarely perforate freely. That is extremely unusual. A small fraction of people do that. So listeners don't have to be super paranoid that that's going to happen. It's not for the large majority of people. And some people actually get scarring from acute diverticulitis as it heals. It can scar down and cause a narrowing, or we call it a stricture, but basically a narrowing, a scar in the colon, the area that was inflamed, that can cause blockage later on afterwards, or even during, actually.
For a patient who is treated observationally for mild diverticulitis found on CT, but the pain never really resolves completely and it just kind of lingers on, what do you recommend should be done next for management after they've been treated with a one-time course of antibiotics, or potentially without antibiotics?
Or not. Well, hopefully we'll come to that point, because Ben is teasing our listeners a little bit with the fact that we're trying to use less antibiotics, not to get ahead of you, Ben, but we'll come back to that conversation. But let's assume most people do get antibiotics. They got treated, and they mostly felt better. They don't have fevers. The pain is going down. But now they still kind of achy, and it's going on, and it's a little icky. And that's a challenging thing, actually. So the first question is that, are we worried that that's still an ongoing infection, or is that kind of just an irritable bowel after that infection? And that can be challenging to do. And if we have doubts about that, we may need to send the patient back to an ER. I don't like to do that, but if they're certainly having fevers again, or chills, or fevers, you got to go back to an ER. Most people don't do that. Most people just kind of have a little icky. And we're actually learning that you can kind of get an IBS, irritable bowel syndrome, IBS-like picture after an attack of diverticulitis for a period of time. It can go on for weeks, sometimes maybe even months. And it's just kind of a PTSD of the colon, if you will, a post-traumatic stress disorder. The colon is shocked or injured, and it's a little misbehaved. However, just to make this more complicated for you and your listeners, Ben, there are people who do have ongoing inflammation, and they're still having inflammation, and they may need further antibiotics. They may need to get imaged, and it's challenging to distinguish those two. As long as they kind of continue to get better, I generally leave them alone. But if they kind of plateaued and then they tell me, no, Neil, this is worse, well, we're going to have to take a look at that again. I try to not to use Advil or ibuprofen in this population. So that's not a good treatment. And we may talk again about recurrence later, but one of the really important risk factors for getting diverticulitis are what we call nonsteroidals, or NSAIDs, and ibuprofen is the hallmark of that. And I would love to give someone ibuprofen because it's a good anti-inflammatory, but in this case, it's a bad anti-inflammatory. It actually can paradoxically make people worse. So we do try to avoid that. Tylenol is okay. That does not affect diverticulitis. Believe it or not, simple things like a heating pad or a hot water bottle have very good anti-spasm effects on the intestines. And I know it sounds like mom and apple pie and a placebo, but in point of fact, heat via a heating pad or a hot water bottle is an excellent analgesic. It really does break spasm and decrease pain. Peppermint, believe it or not, again, sounds kind of low-tech and low-key, but peppermint has bona fide intestinal smooth muscle relaxating properties. So if we're conceptualizing that these symptoms are kind of spasm of the colon, peppermint can have some benefit in that as well. But it's challenging, Ben. You're correct. There are people who kind of smolder. Most people do not. Most people get sick and they get better. But there's a challenging population of people who get sick, get better, and then kind of don't get better. And they're tough to manage. That's the art more than the science right there.
That is fantastic advice and a great review for our gastroenterologists out there and our primary care doctors too. Now, you mentioned the smoldering diverticulitis, where patients have abdominal pain and continued inflammation found on CT imaging after treatment. The 2021 AGA guidelines state that approximately 5% of patients develop smoldering diverticulitis. Could you tell us a little bit more about how you take care of these patients in your clinical practice?
Yeah, again, the first thing is deciding, are they sort of sick or not, right? And by that, I don't mean that in a dismissive way. I mean, are they genuinely having ongoing active inflammation marked by fevers or chills or shakes or severe pain? Worsening pain is a useful sign. And then they got to get looked at again. They just have to get back to an ER or a caregiver and get looked at again. But let's, for a moment, assuming we're not talking about that population, we're talking about people who just have kind of ongoing ickies. They just feel crampy and painy, and then it hurts. Of course it hurts. There was I sometimes say this, and I don't mean it quite as dramatically as it sounds, but they had a hand grenade go off in there, and it was super inflamed and super angry. And while the infection is gone, the antibiotics are over, there's a lot of trauma inside, and the intestines in general respond to trauma with irritability for a period of time. So this concept of sort of a post-infectious IBS, in this case, a post-diverticulitis IBS, is a very real thing. And as I kind of mentioned earlier, we sometimes use Tylenol. We sometimes use hot water bottles or heating pads. We sometimes use peppermint or other antispasmodic agents to try to relax the intestines there. So in the simplest sense, it's rule out badness. And then in the more subtle sense, it's try to make people feel better and reassure them that over time, they'll likely continue to get better.
That's great. Now, one of the most revolutionary changes in diverticulitis management of the course of my medical career, and it's really cool if you think about it, has been medical advice regarding seeds, nuts, and popcorn, because the age-old dictum that we learned in medical school was to teach patients to avoid seeds, nuts, and popcorn. Now, the 2015 AGA guidelines that you helped co-author addresses this. Could you teach our audience about our current knowledge about seeds and nuts in relation to diverticulitis?
I would be pleased to, because it's really one of the things I've been trying to teach the world about. So thank you for the microphone, Ben. We can blame my grandma for this. Grandma Minnie in Boca del Vista, Florida, I think started this rumor a long time ago. And she was told by her, by Estelle next to her in the mahjong room, or by her doctor, who knows, that somehow, these pockets, these are pockets that somehow sesame seeds or poppy seeds or strawberry seeds, for Christ's sake, are gonna clog up that pocket and cause her to have diverticulitis. And Grandma Minnie spent she's no longer with us, but she spent the last 20 years of her life believing that she couldn't have a sesame seed bagel or a poppy seed bagel or strawberries, for that matter. And I'm sad she didn't live to this new world where she could have had all the poppy seed bagels she wanted. In the 1999 ACG guidelines, Ben, we actually talked about that, and we said, everyone says that, but there's really no data to support it. So, I'm not sure. And then by the time 2015 came around, there was data. Largely, a lot of people, but Lisa Straight, who was in Seattle, now in Madison, Wisconsin, is really done a ton of this work with very large data sets looking at diet and risk of diverticular disease. And the data set's clear. They don't cause diverticulitis. In fact, on the contrary, people who avoid those things may even have a slightly higher risk of all things, because those are part of a good diet, right? Seeds and nuts and popcorn are actually part of a healthy diet. And if you tell Grandma Minnie she can't have any of those things, you can argue she's actually going to eat less fiber. And the science says, no, not true. In fact, probably bad advice. Not only negative, not only ambivalent advice, but perhaps bad advice. So as you noted, it took 16 years, but the 2015 guidelines came out, and we said actively, in 1999, we said, not sure. In 2015, we said, look, that's wrong. Sorry, Grandma Minnie, you're wrong. No one with this illness should be counseled to avoid such things. These pockets, just conceptually, are maybe a half an inch in diameter. You are not going to clog up that pocket with seeds and nuts. It's just simply not going to happen. So we are now, I guess I was going to almost say go nuts, but we are now in a world where, in fact, we think it's harmful to tell people not to do that. And I would love our listeners to all lose that wives' tale, if you will, or grandma's tale in this case, and be very comfortable that there is no science that says anyone with diverticulitis has to avoid those things. Now, are there people on the planet who get pain in their belly when they eat too much popcorn or such? Of course. So don't eat popcorn if you get pain when you eat popcorn. But no one has to be told to avoid such things because they've had a diagnosis of diverticular disease.
And we're definitely helping our patients be happier with their diagnosis. It's frequently, from my experience, when we diagnose patients, that's the first thing they ask about. Is this going to be lifelong that they can't have, popcorn or nuts in their diet? And it's a huge relief to patients. So I really think it's important as gastroenterologists and for primary care doctors too, to emphasize this point whenever we have patients that we're managing with diverticulitis, because they're going to be a lot happier with their lifestyle after they recover. Now, here's a really important point as well. Could a colon malignancy be accidentally diagnosed initially as diverticulitis? And what do you advise that gastroenterologists should be telling our patients about getting a colonoscopy after recovering from diverticulitis, including what is your recommended time interval to wait?
Absolutely. Thanks for bringing that up. It's an important subtopic here. So Ben highlights that you look at the CAT scan and the radiologist says, yeah, there's inflammation and they happen to have diverticulosis. Remember, half of our adults might have diverticulosis. So simply having that doesn't mean that's necessarily the problem. And in a tiny subset of people, it's not really diverticulitis. It was, in fact, it was a colon cancer that looked on the CAT scan like diverticulitis. So that happens. It is very infrequent. I have one in my entire old man career. I have one woman, Cheryl. She was actually quite young. She was in her 40s. She had diverticulitis. I said, let's do a colonoscopy. We went to do it, and actually she got another attack of diverticulitis, what we thought was diverticulitis. We held off another month or two. We finally do her colonoscopy, and she had a little tiny colon cancer there. That's one in my career out of assuredly thousands. So I think our listeners can be comfortable that it is not a frequent event. The other thing we've learned more recently that it's much, much, much more common after complicated. You'd asked earlier, Dr. Levy, about complicated versus uncomplicated diverticulitis. And it turns out that I said it's rare in general. It's really rare after uncomplicated diverticulitis. It is much more complicated. It's still rare, but more common after complicated diverticulitis. So our old guideline said, anytime you saw diverticulitis, do a colonoscopy a few months later to make sure it's not cancer. Our new guidelines are going to finesse that a little further and say, be really cautious with patients with complicated diverticulitis, i.e. an abscess, basically, rather than all comers. We're also going to say, if they had a good quality colonoscopy recently, that's a loaded word, we don't define recently, but let's call it a couple of years, it would be, again, even less likely for them to develop a de novo colon cancer that caused an inflammatory process like this within a year or two of a colonoscopy. But if your patient has complicated diverticulitis and or hasn't had a quote, recent high-quality colonoscopy, and that's, again, a soft subjective term, but for the moment, let's go with it, then, yeah, they need a colonoscopy on the 1 in hundreds chance, I would say, that was really a colon cancer rather than diverticulitis. And then you asked, of course, how long to wait. And you're asking that because the colon's inflamed right now when you're having diverticulitis. So, in fact, that's a relative contraindication to doing a colonoscopy. We don't want to go in and do a colonoscopy while you're having diverticulitis. I'd mentioned it's kind of a little tiny hole in the colon or a perforation of the colon. And we put in a lot of air when we do a colonoscopy. And, of course, we move a scope through. So you could, in fact, cause diverticulitis to get worse acutely. So we hold off. And you asked how long, and I would say at least a couple of months. 8 to 12 weeks is probably a good window. And feeling better. If they're not feeling better, hold off. Like my patient I mentioned, Cheryl, she wasn't feeling better, so we re-imaged her, and she was still having problems going on, so we had to hold off a little further. But assuming your patient's feeling better and they have not had a colonoscopy in some period of time, say a couple of years, they bought one, say 3 months down the road.
Well, thanks for driving those points home. Very occasionally, I'll see a primary care doctor trying to do their best to take care of these patients. And, the patient, is expecting the colonoscopy not to get scheduled for like 2 or 3 months. And somehow an opening opens up and they end up taking an early slot. And we can't do it, until we've let time go by for the colon to really heal. Again, diverticulitis is a contraindication to colonoscopy because we don't want to cause a perforation of those patients. So it's important to really wait, 2 or 3 months after symptoms resolve to continue on with their colonoscopy. And I loved how you reviewed, if they've had a really good recent colonoscopy, that maybe we don't need to be as aggressive with all of those patients, although some patients may still want to double check. Now, over the past few years, and we're going to get into the antibiotics now, we've had several important clinical trials, such as the Swedish Alta trial in 2012 and the Dutch Diabolo trial in 2017, to try to examine the possibility of observing mild diverticulitis patients without a need for antibiotics. Could you tell us a little bit more about this antibiotic-sparing shift in strategy?
Thank you, Ben. I'm so glad you brought that up, because I think it's really important. I mean, the seeds and nuts is important too. It changes our patients' quality of lives. But this is a really important one. And you highlighted a couple of the trials. There's now more than a dozen, and they're almost all Europe. In fact, they're all Europe as far as I can tell. I tried to do a study like that in this country, and understandably perhaps, Americans don't want to forego antibiotics. They were reluctant to do this trial, because if I tried to say to you, hey, you have diverticulitis, I'm going to put you to trial. Half of you are going to get antibiotics, and half of you, I'm going to watch and wait. Unsurprisingly, Americans don't like that idea. However, Europeans are so much better at antibiotic restraint, I think, than we are, and at least the population is conceptually accepting of that. So there's been more than a dozen trials in Europe, Italy, Sweden, Denmark, as you mentioned, and they're all the same design. People who come into the ER with a CAT scan positive diverticulitis. So this is not, I've got a little ache in my left lower quadrant. This is a CT confirmed diverticulitis. Studies of 500 to 1,000 people, literally that big trials. And you take those people and you put them in two arms, a randomized control trial of antibiotics or no antibiotics. Crazy thing to do. 600 Swedes or 600 Danes or 600 Italians, and 300 of them went home with nothing, with tea and sympathy, not nothing. They went home with perhaps a heating pad and maybe some Tylenol and maybe a low-fiber diet for a few days. They were followed and watched, but they weren't given antibiotics. And in every one of those dozen trials, a dozen, and now meta-analyses of those trials, there's no difference. There's just no difference. People don't perforate. They don't need surgery. In fact, the only difference in most of those trials is that the people who didn't get antibiotics go home sooner, basically. That's the difference, is that people stay less time in hospital, and that's assuredly good for you. So that's kind of crazy talk, that you could take this thing that we've always assumed is an infection, that always requires antibiotics, and the Europeans now have a template of dozen-plus trials saying nope. So we came out in our 2015, and this has been going on. You mentioned the trials are 2012 and stuff. So in our 2015 guidelines, we actually came along and said, not everybody needs antibiotics for every attack of diverticulitis. And then a few years later, the surgeons agreed with us. There's a surgical guideline that comes out that says, because surgeons help manage diverticular disease, and they said, yeah, that makes sense. And then, in fact, the American College of Physicians came out in 2021, and they said, yeah, that makes sense. And we are about to publish our newest guidelines, our ACG guidelines, in the next month or two, in fact. And I consider this, still embargoed or preliminary. It hasn't been approved by the board yet. It probably will be this week, but I can tell you it's going to say the same thing, which is antibiotics should be used selectively in patients with acute, uncomplicated diverticulitis. And let me unpack that sentence, because it's an important sentence. The first important word is uncomplicated, right? None of this conversation is relevant for someone with an abscess or an obstruction or a perforation or anything like that. This is relevant for well patients with acute uncomplicated diverticulitis who are not septic, they're not highly febrile, they don't have a white count above X, they're not immunosuppressed, they're not super elderly and frail. You have to be kind of Ben Levy, I would offer this to you, and hopefully someone would offer it to me. Maybe
Thank
not.
you.
Yeah, exactly. But maybe not to my grandma Minnie, who was, at the time was 89 and on oxygen. Probably grandma Minnie's not the right, and has emphysema and takes steroids. Probably not the person you're going to hold antibiotics on. But younger people, non-complicated CAT scans, non-sort of toxic looking, deserve a conversation. And that conversation should say, hey, look, for 30 years we've given everybody antibiotics for this, but there is really good science that not everybody needs them, number one. And two, antibiotics have side effects, real side effects. And we're not going to talk about it today, but my other area of expertise is an infection called C. difficile that comes from antibiotics. It literally is the consequence of antibiotics. So I think people underestimate the risk of antibiotics and overestimate the benefit. And you have to talk to them and say, look, you have something that I think you can get away with. And if the patient says, no, I want antibiotics, they get antibiotics. I'm not in the business of withholding antibiotics against their will. But what I try to do is tell them, in fact, what I often do is I give them the prescription or I send in the prescription. But I say, you know what? Try not to take it tonight. Let's see how we do. And then tomorrow, you can, with my chart, people can email me, every hour on the hour if they need to. I'm around. I'm available to you. Let's keep talking. Let's take it a day at a time and see how you do. I find that giving them the antibiotics is, and usually I'm using Bactrim and Flagyl or something very inexpensive. Usually they're really comforted by having the sort of backstop of the antibiotics. And I think that helps them to take it day by day and try to hold off. And if, less is certainly more with antibiotics. If you can get away from another course of antibiotics, you're better without it. So that's really changed the game. It's hard to get people to buy into that. I wrote an editorial for the Annals of Medicine at one point, trying to tease out who are the safe patients for this, because that's challenging, right? Who are the sort of the right people? And at the extremes, it's easy. Grandma Minnie at 90 with emphysema is not the right person. My 40-year-old guy with his first attack who's super healthy otherwise, he probably is the right person. And where's the line in the middle? There's no line. You talk to your patients and you try to figure it out. But this is now a 15-year-old concept that's hard to get buy-in on, both from patients and physicians. Of course, physicians have risk and liability too, right? It feels safer for a caregiver to give someone antibiotics than not to give it, right? Because you're going to run a risk of they do something bad if you don't give it. And we're in a litigious country where people get sued. So it's challenging for the provider. Patients, again, come from this place of antibiotics good. So everything drives towards overuse in this space. But I'm trying to make the case that for a subset, not everybody, in fact, not even most, but for a small subset of these patients, Dr. Levy, I think we can get away with it, and I think the world's better if we do.
That is a really great strategy. I think having the security blanket psychologically is very helpful for patients, and also it'll minimize a bunch of texting or messaging back and forth through the EMR. But I want to also drive this point home. It's also really important to maintain good contact with these patients to make sure that if we don't treat them, that if they don't get better, that we know what's going on with them, so that they can follow up with one of our nurses or just send us a MyChart message. Having some way to close the loop with them, just to make sure that they're not kind of floating out there and there's not good follow up. So, in addition to that, I just wanted to talk a little bit about risk factors of diverticulitis. Could you go over? I know there's some risk factors such as patients above 65. Opioid use, steroids, NSAIDs, hypertension, diabetes, and even certain connective tissue disorders, such as polycystic kidney disease or Marfan syndrome and Ehlers-Danlos syndrome. Could you just tell us a little bit about this and how you use these risk factors in clinical practice, or is it just kind of more interesting to collect data about who may be at risk when we read these guidelines?
Fortunately, in our practice, Ben, people tend to get colonoscopies, so we tend to know who has it because we see it colonoscopically a lot. Your primary care doc doesn't necessarily know that, but we do because we're often scoping people, and we tell them they have OSIS, right? And then we can talk about things they can do to lower their risk of itis. You mentioned connective tissue disorders. This is kind of a connective tissue disease, and in fact, there's a pretty well-described syndrome of what I would call precocious diverticulosis or itis in patients with Ehlers-Danlos. I saw one last week, actually, a 20-something-year-old woman with Ehlers-Danlos, and she has diverticulosis, not itis. But she has pockets at a very young age. This is generally a disease of 50 and 60 and above. But we do see precocious disease in some patients with connective tissue disorder. We also see kind of a weird little subset of precocious disease in largely men in their 40s. Generally speaking, diverticulosis is equal men and women, at least in our elderly patients. Men, women, the same. However, in the 40-year-old population, men predominate, and it's unclear why that is, but it is. Men seem to predominate in this younger, precocious diverticular disease. Tends to be men with kind of round bellies, and that anthropomorphic, it seems to cluster with my anthropomorphic style and others, kind of more rounder people than leaner people. I don't know why that is. I don't think anyone has teased out why that is, but we do see a little weird little population of, men in their 40s who get this. And then those are both special populations, but most people are in their 60s and 70s when they get this. So that is the most common thing for it. We'd mentioned that, lifetime dietary fiber is probably the most important risk factor in terms of getting it. I want to highlight that there is, so once you have pockets, you have pockets. They are not going away. Nobody, short of surgery, unless we operate on you and take them out, once you have osis, you will die with osis, not from osis, but you will die with osis. These pockets do not go away. But there are things you can do to make them less risky. And fiber is the best established data set that patients, vegetarians, again, I mentioned them before, but you don't have to be a vegetarian. Patients with a higher fiber diet are less likely to get in trouble with diverticulosis than patients on a low fiber diet. The other one I mentioned that I'm going to repeat because it's super important, again, are non-steroidals or NSAIDs, i.e. ibuprofen, Advil, Aleve, Motrin, Naproxen, this class of agents that are really good anti-inflammatories. I got a bad knee and they help my knee feel a whole lot better, but they are not good for our colon. We've sort of taught the medical world, I think, that NSAIDs are a risk for ulcers and gastric pathology, but I think we have underplayed that they are also a major risk for colonic pathology, particularly diverticulitis and diverticular bleeding. NSAIDs are a big risk for both of those things. I think that's the important thing. Smoking matters. I mean, again, there's a million reasons why we should tell our patients to lose weight and stop smoking. Those things matter, and there is evidence that they help. Exercise helps, by the way. People who exercise, rigorous exercise, lowers the risk of diverticulitis. So you could kind of summarize it and just say good, healthy living, really. And it turns out that good, healthy living is not only good for your lungs and heart and kidneys, but it turns out to be good for your diverticulosis as well.
And that fiber is really important to try to prevent colon cancer too. I'm trying to get as many of my patients to really think about this and not just, getting 3 servings of fruit or vegetable per day, but really trying every single meal to somehow sneak in some fruit or vegetables. And it's much easier. And especially if they start off just with breakfast, having some fruit or vegetables in their diet, putting some fruit and some Greek yogurt, something like that. Now, here's a interesting question that I think would be very helpful to get your advice on for both patients and gastroenterologists. So a lot of my patients with recurrent diverticulitis, meaning that they've had it more than once, when they've had a couple episodes of diverticulitis, that, and let's just say, for this conversation, that it's identified on a CAT scan, not just that they were feeling abdominal pain again, but really, truly diagnosed diverticulitis that's recurrent. They're eager to get surgery so they can avoid another episode of this annoying diverticulitis. Could you discuss your thought process about diverticulitis recurrences and when to refer patients to a colorectal surgeon?
Yeah, thanks, Ben. That's a fabulous question. It comes up not rarely. It comes up a lot. So I hinted earlier that these don't go away unless, of course, you cut them out. You could cure someone's diverticulosis by taking out any of their colon that has diverticulosis in it, and they won't have it anymore. But that's draconian, and obviously we would only suggest that in very specific situations. In the old guidelines, we used to say, okay, after you've done it twice, I wrote those guidelines and I miswrote because I wrote in 99, after you've had 2 attacks, let's talk. Let's send you to a surgeon. Let's have a conversation. And of course, surgeons cut to a man with a hammer, or to a man with a knife. In this case, everything is a colon. And so we over-operated on people historically. And then the surgeons, not so much us, I wish I could take credit for this, but the surgeons came out and said, we're probably doing too much of this, and started doing some math and some studies. And it turned out that we're probably operating too early, that patients probably do better if we wait after their at least third or fourth attack rather than their second attack. So the earlier sort of prescription of you've had 2 attacks, go get surgery, went away in 2015, when in 2015 we said should be individualized, which is basically our way of saying there's no number. It's really individual to you. And that is, in fact, what we do now. So, I could, again, at the extremes, it's easy. Grandma Minnie at 88 with emphysema, I'm doing everything I can to avoid operating in that situation, right? But the 44-year-old guy I mentioned earlier has a lot of years in front of them at risk, has a much lower surgical risk, and those are people I might start having that conversation with. It also depends, in fact, on how much of their colon has diverticulosis. Most patients in the West have segmental disease in what we call their sigmoid colon, their left lower colon. It's a discrete area. It looks like the sigma or an S. It's kind of a twisty-turny area of the colon. And it's sort of easier math, if you will, if all of your pockets are confined to a very small place, because then the surgery is a lot easier. You're taking out a little bit of your colon, a quarter of your colon, you put them back together. Nobody misses a quarter of their colon. You do just fine. People are continent and have normal bowels after a sort of laparoscopic elective sigmoid resection for a young patient who has multiple recurrences and isolated sigmoid disease. If your whole colon is got diverticulosis, and I'm not sure what's causing the problem, it's sort of all over, that's harder because I don't want to take out your whole colon. And if I take out part of your colon, I might have put you through an operation and take out the wrong part of your colon, which would kind of stink for everyone involved. So those are some of the features that go into it. We are I actually had a patient recently who chose, so it's a conversation. It's an individualized conversation. I can think of actually the last 2 patients I've sent to surgery, and they're sort of illustrative. They're both younger men with somewhat early precocious disease. One of them's a trial lawyer, and it messed up a trial. And he's like, I can't do that again. My profession depends on me being available, and I can't take another chance of messing up a monster trial. So he said, you know what? I'd rather have planned the surgery for 2 months from now in between trials, so I never do it again. Another patient I sent to surgery now a year or 2 ago, no joke, goes to Borneo to source tea tree oil for soaps. He works for a soap company. I won't say his name so we don't out him. But he literally goes to Borneo and sources soap in the jungles of Borneo. And he got diverticulitis in the jungles of Borneo. Thank goodness he got out. There was a canoe that took him out, and someone gave him antibiotics, and he survived and came home, and he's fine. But rightly so. He says, I can't do that again. I'm not. I said, you're going to give up the jungle, or you're going to give up your sigmoid colon? And he said, I'd rather give up my sigmoid colon. And had again, a lap. We can now do some of these surgeries laparoscopically, so that's less morbid. And again, if you can do a segmental resection, it's not so bad. So, long answer to a short question, Ben, but a small subset, generally younger, healthier people, generally after 3 or 4 attacks is when that conversation begins.
So I have one more question before we wrap up. This has been a fascinating conversation, and I'd like to get your thoughts on, I've been reading a lot about point-of-care ultrasound, or POCUS, becoming a super useful diagnostic tool in certain emergency room clinical trials. CAT scans have an incredible sensitivity and specificity for diagnosing diverticulitis, in the 98 to 99% range. Could you give us some thoughts about this point-of-care testing that may speed up the process? It's much less expensive, it's super quick, and more importantly, I think, it helps us avoid excess radiation to patients by continually doing multiple CAT scans over their lifetime. Could you just share some thoughts about this new technology?
Yeah, thanks, Ben. We hope it's the answer. Sadly to say, I'm not sure it is yet. I want it to be. We want it to be for the reasons that you outlined. If you watch The Pit, everybody gets, everyone gets an immediate CAT scan. They're seemingly back before they even go, and they get ultrasounds everywhere, right? They get like a whole body ultrasound. And that's laudable. That's something we're striving for. And as you mentioned, Ben, there's science now that we can put an ultrasound probe on the lower colon and get a reasonable picture of it. And for the reasons you outlined, CAT scans, these people don't get one. They get more. They come back. They get more pain. And CAT scans are a fair radiation dose. And while no one CAT scan is harmful to any individual, typically, it is cumulatively radiation toxic. And I'd like to limit I've had 2 in my life, or maybe 3, and I like to keep it in single digits as I get older. And I think most of our patients would too. So if something non-radiation inducing could answer this question, we would love it. MRIs have been looked at because they're not radiation, but they're long and slow and things move. They're lousy for the colon. So that's not going to help us. MRI does not help us. Ultrasound should, and I'd love it to, and I want it to. And you are correct, Dr. Levy, that there are a number of trials saying it can do so. My experience has been that it's still a very, very, very small number of practitioners who are good enough at this to do it. And I think in real world, the sensitivity and specificity for that are not even close to there yet. So when our ER docs, right now it's mostly a committed GI person that some of these people, right, who are really good at this. But you got a patient in the ER, the GI doc may not be there. You have a whole lot of ER attendings, and they get to learn ultrasound for X, Y, or Z to look for a pericardial effusion or something like that. It's challenging, and I don't think most of our providers are anywhere near good at it yet enough. So I'm optimistic, but I don't think it's really, again, if you happen to end up in an ER where they're really good at it and they say, listen, we're going to do an ultrasound on your colon to look for diverticulitis, and you say, are you good at it? And they say, yes, I'm all for it. But I think that's a really small subset, unfortunately. So for the near term, I think we're still going to be CAT scanning people, but I am hopeful that ultrasound or some other technology will get us out of this CAT scan sort of cycle.
Well, thank you. It's been so much fun talking with you about diverticulitis management. I'd like to thank our guest, gastroenterologist Dr. Neil Stollman, who's been working with a committee to further enhance and update our ACG's diverticulitis guidelines. We really appreciate you taking the time to share your knowledge with our audience. And for those who would like to learn more, please visit our other Pearls and Polyps podcast episodes. We've been interviewing some amazing gastroenterology leaders in our field to educate physicians and patients. And thanks for listening.